Okay, it is just after 1:01 Eastern Standard Time, and this is another edition of Dr. Yass Live on YouTube. Today we will be discussing, let me just fix this a little bit so we can see what Dr. Yass says. Okay, today we will be discussing the SI joint and why it is so overly diagnosed improperly as the cause of gluteal region pain. I'm just going to focus on the SI joint today because it's just actually shocking how many people are misdiagnosed as that being the cause of pain in the gluteal region, when in almost all of these cases, the cause is a muscular deficit from the piriformis muscle. What most people don't recognize is that the piriformis muscle actually runs from all five bones of the sacral spine. The sacral spine is a fused portion of the spine. There are no discs or anything. The five bones that make up the sacral spine are fused. Then that sits right next to the attachment of the sacrum into the spine, which is what the SI joint stands for, sacroiliac joint. The sacrum portion of the spine, the iliac portion of the pelvis. And so the piriformis muscle actually runs across the SI joint diagonally to the gluteal region. And as a result of that, that actually passes the SI joint. The problem is that when you go to an orthopedist or a primary care or a chiropractor, somebody who is only educated in structure, you can't be surprised that the diagnosis that will be given as to the tissue eliciting your pain in the gluteal region is something structural. That can't be confusing. You can't go to a plumber when it looks like the floor is collapsing and ask a plumber why the floor is collapsing or why the ceiling's collapsing or the wall's collapsing, because the plumber knows plumbing. So he's going to have to be forced to say, well, you've got a leak somewhere or a pipe is faulty, when clearly it's a component of structure where a carpenter would be more apt to be able to provide that. But the problem with the existing medical system is that it's so severely splintered that you can only go to people who are specialized. Each specialist is educated in only one tissue. So when you go to that specialist, they only have one choice of one tissue to establish a diagnosis with. So when you go to an orthopedist, it can't be confusing regardless of what your symptoms are. It wouldn't matter if your hair's on fire. The orthopedist is only in a position to identify a structural component, so he'll just kind of name the one that's closest to the area where you're having a pain. That in no way represents a legitimate diagnosis because there's never been an attempt to interpret your symptoms. Your symptoms being the pain, where the pain is, where the pain begins, where it ends. What brings on the pain? Are there any correlating types of symptoms? Is there a change in your posture? Have you identified that the symptom is brought on by movement or function? All of these types of situations can correlate as to whether the pain is being elicited by a muscular deficit or a structural deficit. When we talk about joints, whether we're talking about the shoulder joint, the knee joint, or even something like the SI joint. Now, what makes the SI joint a little different is the fact that it is not your classic ball and socket joint. So if we look at the shoulder, we have the glenoid fossa, which is the socket, and then we have the humeral head, and we have a pivot joint. We could look at the knee joint. We have the femur, and then we have the tibia, and the tibia is moving on the femur. Classic ball and socket, just a very shallowish type of ball and socket. We have the hip joint. The hip joint, severe ball and socket. The acetabulum is very deep. The femoral head, very deep. And so we have a ball and socket. When we look at the SI joint, the sacroiliac joint, we're looking at two flat types of bones. The end of the pelvis and the end of the sacrum, they're flat and they're held very strongly by ligaments. Now, when we talk about joints, if you want to say that a joint is eliciting pain, that in fact the joint itself is the tissue in distress, well, then you have to justify some rationale for that distress of the joint. Well, when we're talking about joints, what is the purpose of the joint? You know, like the kidney siphons the blood for toxins. The heart pumps the blood. The lung takes in oxygen. So what's a joint? What's its purpose? What's its function? Its function is to allow for range of motion. When we look at all the joints allowing for range of motion cumulatively, that's how we develop motion, function, tasks, the ability to perform activities. We need all these joints to allow us to move. So if we were to say that there is distress of a joint, there has to be one primary limiting indicator, something about the joint that indicates that there is in fact dysfunction, an inability of the joint to allow for range of motion. So if someone is to say that you're having pain at your knee due to a meniscal tear or arthritis in the shoulder, hip, a labral tear, or in the case of the SI joint, something limiting the range of motion, that's the determining factor. The fact that you happen to have pain in the region of a joint in no way is a representation that the structure of the joint itself is what is in distress, eliciting the symptom. Pretty much any joint you can point to have massive levels of muscle surrounding it. So certainly you would have to differentiate the tissue in some fashion by looking at the physical presentation. You can't just arbitrarily say, because I'm a chiropractor or I'm an orthopedic surgeon and I only know structure, that if there's pain in the area of a structure, I can now freely, without any hesitation, say that's the tissue in distress. You just can't do that, because it's bad diagnostics. It's not how the diagnostic model works. The diagnostic model is designed to not just identify a tissue, but to also confirm that other tissues in the area are not the cause. A great diagnosis identifies that the tissue in distress is that tissue. Because of this, I also know that tissues in the area are not the cause because of this. So if we're looking at the SI joint, we must look at range of motion of the SI joint to confirm or refute a diagnosis of SI joint dysfunction. And the word dysfunction is kind of a foolish diagnosis. It's a very generalized type of diagnosis. It doesn't really mean much. Dysfunction means that it's just not working. So, I mean, you could have a strained muscle or a torn muscle, which will impede the ability of the joint to function properly. So I hate that diagnosis for SI joint dysfunction because it's so general, and I think it allows people to kind of be willing to be open to any type of diagnosis or representation that it's the joint simply because the word dysfunction is there. If you want to say there's a problem with the SI joint itself, then we got to be looking at range of motion. And I'm pretty sure everyone who gets that diagnosis is typically through an X-ray or an MRI. There is some type of arthritic change that's indicated. Bam, that's your diagnosis. Not based on physical presentation, simply because an arthritic change was identified. And as I've talked about, probably to nauseam, if anyone has spent a lot of time with me, that is a representation of correlative theory, which is also known as junk science. And that is simply to say, oh, I found an arthritic change. You're having pain somewhere in the region. Okay, I'll just say the arthritic change is the cause. The complete lapse of logic in this is that you can find as many people as those with pain having that arthritic change in the same area who don't have pain. Literally almost the same exact percentage. So if arthritis is to say that it causes pain, then how could you have people who have it in the same percentages who don't have pain? And the scary part when it comes to arthritis is that there's not even a correlation between the severity of the arthritis and the severity of the pain experienced. There are people who have very little arthritic change occurring and massive levels of pain. And then you have people who have severe levels of arthritic change and very little pain. And you would think that if, in fact, arthritis is the cause of pain, as everybody purports it to be, then you would expect that a little arthritis should cause a little pain and a lot of arthritis should cause a lot of pain. And there is zero evidence, none, absolutely none, nothing scientific, nothing clinical, nothing theoretical. So you've got to be very careful with the use of diagnostic tests. I would say that almost every single person that contacts me after going through the medical system for treatment of their symptoms always starts by saying, I'd be happy to send you my MRI or X-ray reports for you to review. And I constantly have to say, there is no value in that. You have been brainwashed to believe that there is, but there isn't, for the very reason that there's nothing that can justify some connection between finding a positive structural variation and the attempt to associate any symptoms to that. You really want to kind of think of these diagnostic tests as finding these structural variations, which is the equivalent to finding out that you have two eyes, a nose, two elbows. It's simply identifying what is, what exists, but makes no attempt to correlate the symptoms to that structural variation because there's no attempt to interpret the symptoms, right? That's typically the way things go for you when you go to a physician to get diagnosed. It's just, here's the results of your test. That's what we're saying is the cause of your pain. So it's foolish. And the same thing can be said, as I said, for the SI joint. Most of the people that I come in contact with, they get some X-ray, find some arthritic change. Okay, that's it. And they give you that ridiculously mild, benign diagnosis, SI joint dysfunction. So let's talk about what the range of motion is at the SI joint and what you can do to check it. So here's you went to these people, you haven't gotten any better, you're on the internet, you've searched out, you found this guy, Dr. Yass, and he's trying to explain to you that the only way to establish the tissue in distress eliciting your symptoms is from interpreting the presentation of the symptoms. So here we are, we're looking at the SI joint, and here's what you need to know about the SI joint and how to test it to know if there's there's such a level of change that change could elicit a pain. So if we look at the sacrum and we look at the iliac portion of the pelvis, the way they work is that the joint is designed to go forward and back when you're doing hip flexion and extension, which is to say bringing your knee towards your chest and back. And then they open and close when you're doing hip abduction and adduction, separating your legs. So this first simple test you can do to check the health of your SI joint is to simply, let's say your pain's on the left side, bring the right knee to the chest, then try the left knee. And this is not, and there's another point you want to understand about these types of tests, these range of motion tests. Positive is not representative of pain. Pain has nothing to do with this. I'm not wondering when I'm doing this test whether you're having pain or not. I'm looking at range of motion. That's the only indicator. So you bring your right knee towards your chest. Now you try the left side, and you see if you have a massive loss of range of motion, and if at that end point it feels like a bone's hitting another bone. Like there's just no way you could get beyond that end point. Not a tightness. Literally, it feels like a bone's hitting another bone. If you have that, well, that would be an indication, a positive indication of some sort of disruption of the function of the SI joint. And yes, that's something that might need some sort of surgical intervention. The other indicator is just separating your legs. And if you see that the left side has a major loss and you kind of feel pain in that area of the SI joint because it's being compressed, okay, well, God bless, you do have something that requires surgery. But if you have been told you have SI joint dysfunction and you bring your knees to your chest the same way and you separate your legs and bring them back the same way, well, the function of the SI joint is perfect. And therefore, there is no way you can say that the tissue eliciting your pain is the joint itself. And therefore, this idea of SI joint dysfunction must be immediately eliminated as the diagnosis for the cause of the pain in the gluteal region. Okay? So, every single person on the globe who is diagnosed with SI joint dysfunction, what is the indicator? How do you determine if the joint itself is in distress? Check range of motion. The way to check the range of motion of the SI joint is to bring the knees towards the chest and look if there's a major loss of range of motion on the affected side, and bringing the legs in and or out and in, separating them to the side, seeing if there's a major loss of range of motion. If there is no loss of range of motion, the SI joint is as healthy as can be, and that diagnosis must be eradicated from the possible causes of your symptoms. That is absolute and irrefutable. This is coming from a gentleman who has the ability to differentiate all possible tissues in distress. That's the point. That's what the Yass method does. It ignores diagnostic tests. It interprets the presentation of symptoms. A structure will have a presentation of symptoms. A nerve will have a presentation of symptoms. Muscle will have a presentation of symptoms. So unless you're willing to evaluate the symptoms, you have no chance of establishing the tissue in distress. And as long as you go to somebody in the medical field who is isolated in their understanding, that's pretty much understood, right? The orthopedist is never going to give you a neurological diagnosis. The neurologist is never going to give you an orthopedic diagnosis. The chiropractor is always going to tell you it's from your spine. The physical therapist just does whatever the referring doctor tells them to, right? The rheumatologist will always tell you you have arthritis as a cause because that's what they're educated to say. People are confused when they go to the medical system and they think that when you're given a diagnosis, it's a diagnosis out of hundreds of potential diagnoses. It's not. It's a diagnosis out of one or two. The one or two that they have been trained to always provide as a diagnosis. That's the way it works. The Yass method, through its interpretation of symptoms, will tell you whether it's a structure, a nerve, a muscle. Most importantly, it is shown over 27 years that the tissue in distress in most cases, over 98% of cases, is muscle. That should scare the crap out of you, considering a muscular cause will never be identified by any element of the medical system, because the primary mechanism for diagnosing, which most people have established, is MRI or X-ray. And these diagnostic tests do not find muscular causes. The four primary muscular causes of pain are a muscle straining and eliciting pain, or a muscle that was trying to assist, and that breaks down. So it's a muscle eliciting pain. It can be, in the case of this nature, or the knee or the shoulder, you can have a muscle that attaches to a joint, which is not strong or balanced to other muscle, causing a misalignment to the joint surfaces. They're not aligned exactly as they're supposed to allow for the joint to work properly, the mechanics of the joint. So as a result, the joint surfaces rub in a way that they shouldn't. So you might have pain at the joint, but that is not an indication that the structure of the joint is failing, eliciting pain. It simply could be that the joint surfaces are misaligned due to a muscular deficit, weakness, or imbalance. So that's the second way that you could have pain at a joint due to weakness or imbalance of muscles that attach to the joint. You could have a muscle referrer symptom. Most people have never even considered this concept. All referred symptoms are from nerves. That's what you'll be told by the medical system. Pure crap. Absolutely not. How do you know that? If you're having a heart attack, what's one of the indicators? Pain at the chest and the what? The left arm. Is anything wrong with your left arm? No. What are you feeling there? A referred symptom from the heart. What is the heart? A muscle. So muscles can refer symptoms. And for all those people that are laying on their shoulders, ending up with tingling in the hand, that's not a nerve root. That's not a neurological or circulatory issue. That's the fact that you slept on your shoulder, the head of the arm bone got drawn forward, it overstretches the rotator cuff. And as a result of that, the rotator cuff strains and elicits symptoms. If you were to look up, Google infraspinatus trigger point chart, you would actually see that one of the muscles of the rotator cuff called the infraspinatus can refer symptoms all the way down to the hand. So that's a case where we have a muscle referring a symptom. The fourth one is where a muscle strains and actually impinges on a nerve. The classic case of that is sciatica. So we have the sciatic nerve eliciting a symptom, but it is being caused by the gluteal muscle, the piriformis, straining and impinging on the nerve, a muscular cause creating a neurological symptom. So that's why you have to be able to identify muscular causes. Those four causes that I just described, muscular causes, account for 98% of the causes of pain globally, not just in the United States, globally. I've had a whirlwind of people that have contacted me for Skype sessions and Zoom sessions from Australia, from Portugal, from England, from Ireland, from Canada. These are all people in the last month I've done Skypes with. And it shows you that the issue that I'm discussing, the issue of chronic pain, is a global epidemic. And it's a global epidemic because the global medical system continues to believe that the answer to identifying the cause of pain is muscular, is through diagnostic tests such as MRIs and X-rays. That's the answer. Improper diagnosis leads to chronic pain. That's the way it works. It simply is what it is. The worst part of it is that, and I've discussed this recently with a lot of people, is that if you notice, you go and maybe you get physiotherapy or you go to a chiropractor and you just keep paying and they just keep billing insurance companies, right? And what do you notice? Whether you get better or not, they get paid. That's the nature of the system. That's called fee for service. They get paid their fee for simply providing the service. There is no requirement for outcome. Well, once you don't connect payment to outcome, what the hell is the point of trying to get anyone better? Why should I? I'm much better off if people don't get better, and assuming the person doesn't recognize there's some alternative like the Yass method that sits completely outside the medical system, they stay in the medical system. That's why that person you'll find who's had their 5th or 6th back fusion, nobody in their right mind thinks that's a good idea. But if you don't know there's an alternative and you both coerced into thinking that that diagnostic model's the right way and they keep telling you it's a disc, what alternative do you have but to believe them? As long as you don't know there's an alternative out there that has a possibility of identifying something different. So you just stay in the cycle and they continue to attempt to try to convey to you the problem is you. You're the one that's causing the pain to sustain. It's not them. It's not that they're not doing the right thing. They're doing everything right. It's you're not responding to their treatments. That's what they're going to try to convey to you. It's just foolish nonsense. Foolish nonsense. So when we go back to our SI joint dysfunction issue, and I've mentioned you've tried your range of motion and you have clearly indicated you have full range of motion, we've eliminated the SI joint as the cause of pain in the gluteal region. Let's see if we can pick up some other indicators as to what it is. Well, as I mentioned, the piriformis muscle actually passes the SI joint from its attachment to all 5 sacral spine, running diagonally across the SI joint and the gluteal region to the hip joint. Well, what would be indicators that the piriformis muscle is the cause of pain? Well, you could actually do some palpation, touching, right? And maybe you feel near the SI joint, but then you continue beyond the SI joint diagonally across the gluteal region towards the hip joint, and you're feeling, shit, there's pain even way outside of the SI joint. I'm feeling it all the way, and I'm feeling thickness actually into the gluteal region. Well, you wouldn't be feeling that if it was your SI joint. What you're really doing is just feeling your piriformis muscle. And if it's not an eliciting pain, that's known as point tender pain. A symptom indicating the tissue you are pressing on is the tissue that's eliciting your pain. So we got that. Okay. Well, why would the piriformis muscle strain? Typically because the gluteus medius, the muscle that sits on the outside of the joint here, we can actually turn this a little bit. If we're looking right here, that is your gluteus medius muscle. It's on the outside of the pelvis. It attaches from the pelvic rim, the gluteal fossa, all the way down to the hip joint. This muscle, when it strains, it's responsible for providing balance and stability in the joint. And when standing, it keeps your pelvis level. And that's what gives you balance and stability. Well, if it were to strain, right next to it is the SI joint, is the piriformis muscle, and it's attaching from the sacral spine, which would be over here, running on a diagonal to the hip joint. So it's sitting right next to the gluteus medius muscle, right here. So what happens is there's a hierarchy of the way muscles work. When the first muscle strains, another one tries to compensate. And that's what's happening. The piriformis is going to strain because it's not in a position to help provide balance and stability, but it's just trying to help out its friend, the gluteus medius muscle. So usually that's the cause. What would happen? What would be an indication of a glute med being weak? Everyone would try to put their hands on their pelvic rims, which is this right here. That's your pelvic rim. So if you were to put your hands on there, you would find that they're not level. One would be higher than the other. That is an instant indicator that the gluteus medius on one side or the other has strained. Okay, so that would be it. Now let's look at a functional limitation. So we try to have you single leg stand, squat, and hop on one leg and then do it on the other side. If you found that one leg, it was easier to do than the other leg, you've just shown that the gluteus medius is weak, and that's why you're having that dysfunction. What would be some of the indicators? Beyond the actual difficulty, there is a degree of difficulty in doing it. Well, when you were to squat, you might find that your knee caves in as you're doing the squatting down on the leg that you're squatting down on. That would be an indicator. If you find your balance is difficult, if you find you side bending to the side you're standing on, all of these are degrees of difficulty and attempts by the body to alter itself because of the weakness of the glute med. So those would all be indicators of a weak glute med. So we have altered hip heights. We have a difficulty in doing single leg stand, squat, and hop. As you do the stand, squat, and hop, you might find the knee caving in, especially with the squat. You might find yourself side bending. So what we find are there are clear physical, and then you could actually press into the gluteus medius again. If we were to press right here, you might find some massive pain. So if we use palpation, we use muscle testing. We can muscle test the glute medius on both sides, see if it's weaker. We can do functional testing and postural testing. All those would be indicators that the cause of the pain that you're feeling, which you were diagnosed as having SI joint dysfunction, are actually a strained gluteus medius causing the piriformis, which would be sitting here, to overwork, break down, and elicit pain. So then you would simply have to do a series of exercises, hip abduction, hip extension, hamstring curl, 3 to 4 exercises. That's all it would take. And you would resolve the pain in the gluteal area, and you would have a complete return of function. That's what this is about. So you come across the Yass method, you're going to find this as the only diagnostic method outside the medical system that ignores diagnostic test findings like MRIs and X-rays and is promoting the use of an interpretation of the body's physical presentation of symptoms to establish what tissue is in distress. In 98% of cases, the cause is muscular, and therefore progressive resistance, causing muscles to adapt to greater and greater resistance, is targeted, meaning that we're going to do an isolated exercise for each one of the affected muscles, will allow you to regain your strength so that the force output of your muscles is greater than the force requirements of your activities, and you'll be able to function perfectly without symptom. So that is the end of this discussion regarding SI joint dysfunction and why it is so grossly misdiagnosed, and why, after an attempt to be treated with that diagnosis, you simply do not resolve your pain. So If you like this video, by all means, give it a thumb up. If you think it's educational, if you think you're starting to understand what causes your symptoms, in this particular case, in the gluteal region, and how to resolve it, please give it a thumbs up. If you like my channel, my YouTube channel, Dr. Mitchell Yass, this is an example of the type of information you're getting. Please subscribe. That will allow you to get notifications every time I add a new video or when I am in fact live on YouTube Live. That allows you to contact me during these sessions and ask questions if you choose. If you want to contact me, maybe you just have a personal question, you want me to investigate something that's going on with you, you can contact me through my email address, drmitch@mitchellyass.com, DRMITCH @MITCHELLYASS.com, DRMITCH @MITCHELLYASS.com. If you would like to actually have a session, even though the coronavirus is running rampant and you think there's no way of resolving your pain, you can. For at least 6-7 years now, I've been using Zoom and Skype well before this telemedicine boom developed. That is because of the nature of the fact that I've been contacted globally. The general population was not flying to Florida just to get treated. They can tell, and they've seen that the use of this type of situation, Zoom or Skype, is highly effective in establishing the causes of symptoms. There are rare cases where it's so complicated that it might limit its ability to be treated without in person, but that is a very, very small amount of the situations that I found. The vast majority, this works exceptionally well. And so if you'd like to set up a Skype or Zoom or you want further information, again, contact me through my email address, drmitch@mitchellyass.com. That's about it for now. I just want everyone to realize that the Yass method sits outside the medical system. It is the only true mechanism for diagnosing the cause of pain, and I hope that everyone who gets a chance to experience it or comes in contact with it recognizes the value and tries to help me to spread the gospel of the Yass method. Help me reach more people. There's only one way we're going to end the global chronic pain epidemic, and that is working together to try to alter the existing medical system and its use of diagnostic tests and get them to integrate, or simply get the population, forget the medical system, and just get the population to move towards the use of the Yass method and its mechanism of diagnosing through the interpretation of symptoms, the only legitimate, logical way of understanding what the body is trying to tell us. Right? So for now, this is Dr. Mitchell Yass. I hope everyone has a wonderful not Thanksgiving, but July 4th weekend. Be safe. And more importantly, let's all be pain-free and fully functional. So for now, bye-bye. Dr. Mitchell Yass. So long.